Welcome to everybody. We appreciate your joining us and we're looking forward to the conversation. I'm Jim Wood. I'm chairman of Wood Communications Group, and I serve as strategic counsel to the Concerned Actuary Group. The quick background on this effort, which we call the American Healthcare 2021 Now What, is that the concerned actuary groups believe that we need to improve the decision-making process for healthcare in this country. In the midst of the conversations when the pandemic hit, we decided to engage in a series of conversations with experts and prominent folks from around the country, to see whether or not they saw the same kind of challenges and problems and the horizons that we saw, and then to help drill down on some of these and package them up in relatively accessible digital formats to try to get this information to people who are knowledgeable, people who are heads of trade associations and delivery providers and policymakers, to begin a dialogue, to begin a discussion. What we will be doing over the next 2.5 months is releasing 5 programs. You've seen the first one, which is focused on the context. The second is focused on disconnects. The third is focused on the importance of holistic analysis. The fourth is focused on the development of the Concerned Actuaries Comparable Actuarial Assessment Model, the CA2M, and demonstrating its predictive capacity related to the Affordable Care Act. And the fifth program is focused on demonstrating how the model, we believe, could be of use to policymakers and decision makers. As indicated, we're going to start by focusing on the 3 topics that were identified in the materials that you received. Mark and Ron, who developed the CA2M model, will be available to take questions, to interact with your comments in each of these areas. Let me start with the first topic of discussion that we indicated, which is the fundamental problem, and our statement that the nation's healthcare system, as currently configured, is not capable of delivering affordable, quality care consistently, equitably, when and where needed. If you've had a chance to look at the program that was sent out, you will know that if you did a word map of that conversation in terms of what the context looks like, you would hear things like unsustainable cost shifting, reimbursement, negative side effects of reimbursement schedules, complexity, lack of transparency, interface with patients is impossible to negotiate or navigate. Summed up ultimately by Mark, I think, saying too much demand, not enough supply, endless deficits is simply not sustainable. And I'd like to start, when you talk about the fundamental problem, essentially, I think what everybody on that panel discussion said was the current program doesn't deliver and isn't sustainable. Okay. And I guess the question for those of you who have joined us today is whether that's the same horizon you see, whether you think we are being overly negative or too positive. Did we miss something? So let me start there.
Mike Quist, President and CEO of WA Trust and Health Tradition Health Plan. And from our perspective, we've seen health insurance become unaffordable. So the care, even if you're covered by the insurance plan, you can't afford the deductibles, copays, or co-insurance. It's a race to the bottom right now. In the 10 years I've been at WEA, we went from $100 individual, $200 family deductible, now to probably the average is somewhere around $3,000 to $5,000 individual and $5,000 to $10,000 family for we've sold to public sector employees primarily and teachers, and they're making $40,000 or $50,000 a year. That isn't sustainable at the trajectory that it's been going.
David Walker in the program says that he thinks that the system needs to basically deal with preventive care, wellness, and catastrophic, and that there ought to be a national standard. What's your reaction to that?
Well, when I was a child many years ago, the doctors came to the house and parents paid in cash for that visit, right? So primary care was handled out of pocket, and you had major medical to cover hospitalization and what have you. And I think what we've done is overinsured the healthy and underinsured the sick.
I want you to know what you already know, but I want to say it as a physician. Physicians are as dissatisfied as anyone else, and many are more dissatisfied. I'm involved in a few international and national study groups where everyone is at wit's end. And basically, what I see from a doctor's point of view is restraint of trade, credentialing, and other things that make absolutely no sense, that keep people who are needed out of markets.
Could you elaborate just a bit on that, Doctor?
Well, when you go from one state to another, you have to be credentialed. Now, of course, they're going to call the medical school, make sure you went to medical school. That's a good idea. But they're also going to call your internship program, and you've got a job now as a doctor. You have a specialty. You're a subspecialist usually, and it can take a year to 18 months to 2 years to do this. And there's nothing that a physician can do about it. And what it does is discourage people from going where they're needed. And one of the examples of that actually worked is in this pandemic, where people were allowed to go wherever they were needed or wherever they were willing to go. And so it is not impossible at all. And I think a simple order from whoever's in charge, maybe the president or so, I don't know who, but making it like it was in the pandemic, where nurses and doctors could go where they were needed.
So in Wisconsin, we're short thousands of nurses. The challenge in terms of training and recruitment essentially winds up at a bottleneck in terms of the capacity to train and educate and certify, because we don't have enough professional nurses teaching. And we are told that we live in a world where it is the national nurse profession, per se, that lays out requirements that you can't teach certain courses at most four-year colleges and universities without a PhD in nursing. And I'm wondering, so when the doctor talked about credentialing, is that an across borderline issue, or is it alone, or is it also a question about the kinds of credentialing decisions that were made years ago? So, and I'm wondering whether that's not also an issue.
It is, and it's a big issue that doesn't make any sense to me as a physician. One more point I'd like to make is that as a federal physician for 28 years, I could work in the NIH, I could work in the Indian Health Service, I could work in any of 130 VAs around the country, I could work in VA clinics, I could work, and the problem of credentialing did not exist. So it is, the VA is a huge system. The Indian Health Service is not so large. The military medicine also is included in this. So there are many millions of people that are covered by a system that does not require credentialing every time you move to a new hospital, and certainly every time you move to a new state. So there's good models of this in the healthcare delivery system that work.
And Mike and now the doctor sort of brought up this issue of need. And so in our modeling, we have actually changed the definition of coverage to focus on both the assets or income of individuals as well as their health status, because it's very important. If you're giving subsidies to people, you want to give them enough. So there's a lot of people that have what we call inadequate coverage, but there's also a lot of people that we call disproportionate or excessive coverage. And we're finding it changes over time. We're getting more and more people going into the disproportionate bucket. And then to the doctor's point, we also have an access part of the model. And we really do need to get to these questions of where services are needed. Of course, we know from the modeling we've done that there's shortages both of nurses and of doctors in many cases, particularly in rural areas, but certainly in other places. So this whole issue of need and versus the supply is a really critical element. And when these things when supply and demand get out of balance, which we'll talk about more and more in these sessions, it really creates a lot of distortions and a lot of issues. So thank you for, both of you for bringing that up.
A related point that was brought up in the first conversation, has to do with the relative underinvestment in primary care and preventive medicine in comparison to specialized medicine and high-tech, high-expense interventions. So that seems to fit into this part of the dialogue as well. That you know, the encounters that people have with their primary care physicians are getting shorter and shorter, and there's a lack across society of enough focus on staying well rather than intervening in a serious illness with high-tech medicine.
But it seems to me that this is a system that has evolved like Topsy. You know, you just kind of kept cobbling a piece on as something became popular or something became possible politically or what have you. And what I think the challenging piece is trying to understand why a nation of people and highly trained professionals somehow haven't been able to say, well, wait a minute, this is not what we ought to be doing. We need to be doing this. We need to be doing that. It's in that context that I ask, you know, how did we get to this point? And obviously the second question is, what do we do from this point?
I would like, in a perfect world, from an insurance person who's been in the insurance industry in different lines of business for 40 years, I'd like to see this be an individual purchase. Get the employer out. They can contribute and do a defined contribution plan, and then let people go find the healthcare that works best for them. I think the employer in the middle creates a number of bad behaviors. So if you consider health insurance as an employee benefit, well, what do you do as an employee? You try to maximize your benefits. And, you know, we could see in our numbers what we call a benefit rush toward the end of the year when deductibles are satisfied and people get care that they think now is free. Well, care isn't free because the insurance company doesn't take on any, they just repackage it and pass on those costs. So I think if you made it an individual choice, and we do have our state plan business where payers compete to get onto that exchange, and then employees make individual choices as to who they want to go with. That has proven to be much more effective at controlling costs than the employer side of things. And now you have, you know, employers at 100 employees, 200 employees going self-insured, or one cancer case will blow up their experience and they can't afford it. So the larger the pool from an insurer perspective that you can have and spread costs you know, across everyone, allows you to mitigate those increases. But the game that is going on in Wisconsin right now is just, and around the country, is just not sustainable. What we have seen success with, and this was mentioned a little bit earlier, we started an HMO plan, and it focuses on primary care. So we want our primary care visits to be 30 to 40 minutes, not 8 minutes. And we want a lot of things done in the primary care setting that don't have to be done in the specialty care setting. And it's early on, we're about 9 months into it with our first substantial group, but the results have been tremendous.
Much, but there's another company that I am familiar with that the model is very, very similar to what was just discussed in terms of the Wisconsin-based HMO. The organization of the delivery is built around primary care. And in this case, the primary care organization is taking responsibility for the risk and the budget for subsequent specialty care. And they very much are spending their time developing these deeper relationships with the members and spending a lot more time on primary care. And by so doing are much better able to head off a number of acute episodes and make sure that when an acute episode does come to pass, that it's being well attended to and well managed, and that there's not a recurrence right after a hospital discharge, for example. And that's proving to be very effective. So it is a model that has some promise.
Somewhat unrelated comment, but an area in which there's actuarial wisdom that can be drawn is if you look at the history of life insurance, over the years, more people have become insurable and the cost has continually gone down. So it might be worth pondering what's going on in life insurance and why is it different than what's happening in healthcare?
That's a great point. So in our modeling to date, which we'll discuss, it's pretty clear that the health status of the population relative to morbidity is getting worse. And that takes off aging and things like that. I mean, it becomes pretty clear when you start looking at the modeling work we've done that the population health is getting worse, which is just the opposite of what's happened in life, as you've talked about. So that'll be a great discussion point. And of course, cause and effect relationships are a critical assessment there, because you do have so many different populations in the United States. There's so much segmentation going on that it gets into a lot of issues about risk classification and so forth. So pretty dear to the actuarial heart.
Over the last couple of years, as we talked about all the things we just finished talking about and that were highlighted in the advanced program, one of the things that became apparent was if you wanted better informed decision making, you had to ask how you got better informed decision making. Obviously, a piece of that is the whole incentives question and the political process and all the rest of it. But at the same time, you needed, we thought, better tools to inform the political process, the decision-making process in real time. And that's that in real time piece that we think is an essential part of the go forward. So what's been done is that they've created a matrix grid, which by weighting responses and numbers that come out of these, there are 48 intersections. So across the top, they've identified market impact, signal areas, cost coverage, access, health status, economy, and sustainability. And down the other axis, they've got the delivery, the major delivery mechanisms. Okay. You got 48 intersections in which you can make a judgment based upon the data that goes into the model, and it will show it having either a positive or a negative effect. So Mark, what I'd ask you and Ron to do is to talk about, just lay out for folks who may not be familiar with the CA2M, where you started in terms of your matrix grill and what you're trying to get done.
So what we did was we realized that we had a serious problem in healthcare, but that we really needed, and as Alan talked about, we really need to look at it much more holistically. So we developed a model, but we've now we've linked it into the economy, into GDP and a whole series of pieces, and added in a lot of behavioral considerations. So we look at cost, but we look at cost across development across a whole series of elements, starting with the cost of services nationwide, the reimbursement to providers, how people change their behaviors with the level of coverage that they have, how managed care interacts with that, how as you move between markets, how does behavior change? Because so the model has in what we call population factors or influences and market influences. So the population influences are age, health status, and income and asset levels. The market forces or influences are the things like level of coverage, how utilization changes, managed care levels, how that changes, the reimbursement levels, the availability of providers, which is a critical thing, because you can get coverage, but if you don't have access to treatment and quality treatment, so all these interactive forces. And so the model reflects how people based on looking backwards traditionally, and not only just United States, but we've also looked at data in other countries, such as in Hong Kong and in South Africa, for examples, where we've had some reforms and how people have modified their behaviors and what happened to their access to treatment, and therefore what happens to their health status. So, and then that links into the economic. So as you go into Medicaid, for example, where there's limits on how much you can make, how does that affect the GDP? If they become uninsured, what happens if they suddenly go from uninsured status to covered status, whether that be Medicaid or otherwise? And so there's all these factors, and what we're trying to do is what Alan sort of talked about, is give a holistic look. So we're trying to look at value, which is a tough thing, and it's not just monetary value, but because in healthcare, you have cost, which is monetary, you have access to treatment. So if your health is terrible, it may be monetary, but there's obviously a great impact on your ability to work and your productivity. So the model is trying to assess across all these things, and as one piece changes, it changes elsewhere. And what happens across the system is we put in modifications, whether it's reimbursement under Medicaid to providers, whether it's guarantee issue or community rating, whether it's changes in drug coverage or whatever. And that's what the model's about, is a very quick 30,000 foot overview.
Just in, I think our observation was that even significant policy level decisions and changes introduced to the system seemed to have a characteristic that they were intended to do something, and yet people didn't consider, or they weren't able to foresee, all of the other implications that such a change would have across the system in various ways. And so the idea of a more holistic model is to put together some sort of a capability to take a change that's on the table, being considered, and think through all the different implications of that change across a number of different variables. It might be a change, at one point I put together an example where the change that was made was to change Medicaid eligibility rules. And the intent was, we need to get more people covered. Well, that's a pretty direct cause and effect thing, but I made a list of at least 6 other pretty direct impacts, most of them adverse, that actually came out of that. And from those 6, here's another 9 or 10 that are derivative of those changes and implications. And some of these things cycle through iteratively a number of different times. And that kind of analysis just doesn't seem to be available. There's too much thinking, cause and first effect, not all the other implications. And could this be designed better, or could a different change actually serve our interests more holistically in terms of the whole performance of the system?
From my vantage point, what this model enables us to do is to say, this is what you said you wanted to do. So your objective in making this recommendation or this proposal is X, Y, Z. When I run your proposal against this model, I find challenges. I'm not telling you that your motives are wrong. I'm not telling you that you can't do it. I'm saying that what you put together based upon this model of analysis suggests that you need more work, okay? And it may be that you need more work in the cost piece. It may be that the model suggests that you've underestimated the adverse effects of discounted reimbursements in terms of access, okay? And that in turn affects health status, et cetera. So that's this matrix presentation and the capacity to show the interrelationship, I personally think is potentially a game changer.
Will your work include an example of something like that that would be eye-opening for a lot of people?
Yes, we've already done the ACA analysis. So we took the data. We actually have a model from 1950 and 1992 and 2008. So we we ran it using our data through 2008, ignoring any data post because the law came in 2010. And we can show what the model predicted versus what actually happened. In the later sessions, we're actually going to go through those beta tests and show you what's come out. And we'll certainly be very interested in everybody's input but it's an actual process. You go through the data, you decide what's credible, you try to make judgments about what's happened in the past and use those to project the future.
This model remains a work in process. This is not a finished product. We still probably are stronger in the ability to, in detail, analyze cost and coverage, the health actuaries' background coming into play. And I think we could definitely continue to strengthen this model in its depth and detail with respect to the economy, access, and maybe to some extent even health status as well.
We see this developing in stages, but as we've proceeded, the model gets more complex. So we just want you to understand that this is a process that's ongoing, and the purpose, as Ron said, is to improve decision making and create a holistic analysis so that you start to assess unintended consequences before they actually happen and become even a bigger problem than perhaps what your initial problem was. Thank you to everybody for participating. And again, as Jim said, we look forward to further participation in improving it and making a difference.
The ask is pay attention to the information if you would. If you think it's worth sharing, please share it. Okay, we're interested in getting further reach and encouraging other people to take a look at this and to engage in the webinars. And we hope you'll all come back and join us.